Now, next speaker is Professor Bancha, and he talk about posteromedial meniscal repair, indication, technique, results, and role of osteotomy.
So this is my preferred topic. I did a lot of meniscus root tear. So I'm talking about the posteromedial meniscus repair, indication, techniques, and results, and the role of osteotomy. Okay. So thank you, my fellows. I use many fellows, totally 6 fellows for preparing the talks. Okay. Thank you all of them. Okay. Dr. Soy from Philippines, Dr. Sulasak, Dr. Panuwat, and Dr. Lawrence from the Philippines and Thailand. So this is anatomy of the meniscus root. First, you need to know the anatomy of the meniscus root. There's a medial side, lateral side. This is a medial side, right? The medial meniscus root, the posterior meniscus root, we are talking about this today. It really close to the PCL, okay, about 8 millimeters. This is a study from Raprat. And the anterior part of the medial meniscus root is about 9 millimeters from the ACL, okay? So this is for the medial side. For the lateral side, the posterior meniscus root is far from the PCL, is about 12 millimeters from the PCL, and anterior root of the lateral meniscus is very close to the ACL. So very careful when you do ACL reconstruction. It's only 5 millimeters. Sometimes you can damage the anterior root of the lateral meniscus. So what is why is the root important? Because the meniscus root is the anchors of the meniscus to the tibia, preventing extrusion of the meniscus. So the root meniscus can convert the axial loading to the hoop stress. So when you turn the root, okay, the meniscus will extrude out of the joint because of loss of the hoop stress, loss of hoop tension. So one study found that if you turn the meniscus root, is equal to total meniscectomy. Okay, so that is the very bad. It looks very trivial, but actually this is very bad situation of the meniscus. Okay, similar to total meniscectomy. So for the medial meniscus root, it happened in the middle age, right? Like 50 years. And always the mechanism injury is very trivial. Sometimes the patient cannot recognize the mechanism of injury, like deep squatting in the toilet, or miss the step, or twist. Okay, sometimes they can feel pop. Okay, but most of the time there is no effusion in the joint. It's not like ACL. Okay, for the lateral side, it's different. It's happened in the young, and it's combined with the ACL injury. Okay, and this kind of patient will have severe pivot shift positive. Okay, so this is the difference between the medial root tear and the lateral root tear. So from the examination, the patient may have the joint line tenderness, okay, pain on deep flexion, McMurray test positive. Okay, and for the lateral meniscus root, the patient may have severe pivot shift positive. Okay, and pain on deep flexion. So the risk factor for the root tear is the patient have malalignment, especially Wallace malalignment, older age, increased BMI, and female sex. This is a clinical risk factor. So this is a classification from Raprat based on the tear morphology. Okay, we have totally 5 types, right? The most common type is type 2. Okay, it's like the complete radial tear. Okay, about 9 millimeters from the attachment. Okay, this is the most common pattern, okay, of tear. So this is the full radiographic findings for the meniscus root. Okay, if you have chronic meniscus root, the meniscus will extrude out of the joint. We call this a meniscus extrusion. Okay, and the meniscus disappear from the sagittal cut. We call this ghost side. Ghost means they disappear like a ghost. Okay, and from the colonal T2, okay, you can see the cleft, okay, the gap between the meniscus to the PCL. Okay, and sometimes you can see the maloedema, okay, especially at the tibial site. Okay, so this is a classic MRI of the meniscus root. For the lateral meniscus root, sometimes it's difficult to interpret. From the study, we found that nearly 1/3 the radiologists will misdiagnose because it's difficult to interpret the lateral meniscus root because sometimes you can not see the gap. So this is a classic meniscus root. For the lateral side, you have the Humphrey, the mesocofemoral ligament, Humphrey or Risberg, right? And also the root is like Y-shaped. Sometimes the meniscus root tear and you can miss it from the MRI. But intra-op, you can see that the meniscus is floating. Okay, sometimes you cannot see the gap, but it's floating. So natural history of meniscus root, when it's torn, it will detach from the plateau and extrude, okay, escape from the joint, and finally the patient would have cartilage loss or rapid progression of the osteoarthritis. Okay, so this is a natural history. So one study we found, they found that the osteonecrosis associated with posterior meniscus root tear up to 80%. Okay, this is one of my patients. The patient came to see me because actually he had meniscus root tear, but the patient denied the surgery. And 2 years after that, the patient come back with a medial joint line pain. So you can see from the MRI, this is also necrosis of the femoral condyle. Okay, so this is a very high association with the meniscus root tear. So the treatment options you can divide into conservative treatment and operative treatment. So this is a position, same like I do bucket handle. I prefer this position for every surgery of the knee, okay? So you can assess around the knee. And also, if you need x-ray or C-arm, you can do it very easy. Indication for the repair is the acute or chronic root tear without substantial concurrent meniscus pathology. So we prefer to repair the root as soon as possible. So for the chronic patient that's still active and still have no arthritic change, KL less than 2. So this is a good candidate for the root repair. But if the patient came to see you very late, so that's a contraindication for surgery. So if the patient have subchondral bone collapse, okay, or malalignment more than 5 degrees or BMI more than 30, so that's not a good candidate for repair. If you repair in this kind of patients, it will be fail, okay? So, so when you're dealing with the root tear, so 3 things that you need to concern. Number 1 is the alignment of the knee. Number 2 is the cartilage quality, especially at the medial side. Number 3 is the ligament injury. Is that association or not? Okay. So the good candidate for repair is the patient that come to see you very early. Acute, there may be have the myeloedema, no joint space narrowing, and the extrusion less than 3 millimeters. This is a good candidate for the meniscus root repair. The bad candidate is the patient came to see you very late. Chronic one, start to have joint space narrow, large gap, and extrusion more than 3 millimeters. This is too late to repair. If you repair this kind of patients, it will be fail. Okay. So 3 things that we need to concern. Number 1 is the techniques of repair, suture construct, and the extrusion reduction or not. So we will discuss about that. So about the techniques of repair, you can do the transtibial pull-out repair. So this technique is the conventional way. We do transtibial and repair the meniscus back to the tibia. So I propose this technique. So this is very simple technique. We use the tibial tunnel suturing technique at the beginning. Okay, you put the suture from the tibia using the meniscus needle and repair the meniscus in the Mason-Allen way. Okay, and then use the suture to the post to the button. Okay. So the advantage of this technique is anatomic reduction and also the stable cortical fixation. The disadvantage of this technique is that you need tunnel, right? And sometimes you may have tunnel convergence if you have some combined injury, combined operation like high tibial osteotomy or ACL reconstruction. You may damage the neuromuscular structures because you use the posterior portal. But my major concern is the bungee cord effect because the fixation point and the fixation point is far from the tear site, okay? And it's difficult to adjust the tension, okay? If I use transtibial, I prefer to use double tunnel fixation. So this is a double tunnel fixation. So the trick is that, yeah, this is one patient, 50 years old. He had the meniscus root tear. Okay, so the double tunnel techniques, you may have better contact surface, like you do a double row of a rotator cuff repair, right? And you have only 2 holes, okay, suture fixation to the button. So this technique, you have better contact area. Instead of point contact, you have the area contact using the double tunnel techniques, okay? So from the review, systematic review, we found that the complete healing of the meniscus is vary from 60% to 90%, okay? And another problem is that about half of the meniscus, you have extrusion, okay, that cannot reduce. Yeah, and this is the problem, the extrusion that cannot reduce. Okay, this is the new way using the soft anchor. Okay, you don't need the tunnel. So that proposed by Dr. Somsak, okay, from Thailand, and Dr. Tan. He used the soft anchor. Okay, used the flexible soft anchor for the repair, okay, and the result is pretty good. But some disadvantage is that they could lose or slip from the bone, okay, and need to do MCL release. So I'm talking about the MCL release. Actually, I already mentioned in my bucket handle talk, right? We use the magic point to release the joint. Okay, for the meniscus root, I always do the um, magic point release to improve my visualization, also the working room. Okay, show you one patient that this patient have the meniscus tear. So nowadays I use the soft anchor for meniscus repair, but this technique is pretty easy. You make a tunnel and then you pass the soft anchor into the tunnel. Okay, the benefit of this technique is that your fixation is close, okay, to the tear site, okay, and you can do better fixation, okay, using the suture anchor. So there's a study comparing the suture anchor and the transtibial technique. Okay, both techniques improve the clinical outcome, but one mechanical study found that suture anchor is better biomechanical properties, better fixation, and less problem about the elongation after the repair. Okay, so nowadays the suture anchors technique become more and more popular. For the suture construct, there's many suture construct for the repair. So there's a study comparing the biomechanical properties of the suture construct. They found that the double locking loop have significant higher failure load, right? So this is a double locking loop, okay? And that's another study found that there's comparing techniques. They found that the simple cinch also works very well, okay? The third one, this is a simple cinch stitch. You have single pass and less cyclic displacement. So talking about the extrusion of the meniscus, as I told you that about 50% of the meniscus, even it healed, the extrusion cannot be solved. The patient still have extrusion. From this study, we found that the extrusion of the meniscus may decrease the tensile strength and shock absorption, and also progression of the osteoarthritis. So only root repair may not be enough. If you still have extrusion, okay, the patient would have symptoms. This is another study from Jingu Kim from Korea. They also found that the decreased meniscus extrusion group had worse outcome in Lichcombe score, IKDC score, and also KL arthritic progression. Okay, if they have the extrusion. So this is my proposed technique of the extrusion reduction using the suture anchors. I put the suture anchor at the edge of the tibia and then suture the meniscus back using the mattress. Okay, detach the meniscus from the peripheral and then doing the extrusion reduction. Okay, so the benefit of this extrusion reduction is that the tear site will have less tension. You see that after we do that, we can repair the meniscus back. Okay, this is another way I repair the meniscus to the PCL. Okay, in some situations, right? So after the extrusion reduction and repair, So the benefit of this extrusion reduction is that can reduce the tension at the repair site. So another concern is about STO. Sometimes the patient came to see you very late and start to have arthritic change. So repairing the meniscus root alone may not solve the problem. So these are indications for the STO with root repair. If the patient come to see you early within 6 months, acute tear, extrusion less than 5 millimeters and KL less than 2. So that's a good candidate for STO. So one study from Dr. Pia from Thammasat, they found that the one leg standing view is very good because sometimes you make a standing view, the patient did not put the weight on the affected site. So one leg standing view is different. Okay, I use this one leg standing view. It works very well. Like this patient, when you do the one leg standing view, you can see that the joint space is narrow. You see extrusion of meniscus too much. This is not good for the repair. Okay, so I combine the meniscus root repair together with the high tibial osteotomy. Okay, but sometimes it's not easy because you have tunnel from the suture, right? If you do osteotomy, you may cut the suture, right? So there's some trick that I will share to you is that when you try to do the tunnel, then you can do the osteotomy. You can put the metal sheet, okay, the rim and the button rim to protect your suture, okay, like that, okay? That will protect your suture from the saw or from the screw, right? And after that, you can tie the knot, right? So that's the high tibial osteotomy together with the root repair. Okay. Most of the patient works very well, right? Like this patient, there's only 2 months of the surgery, the patient can walk and the medial joint line pain is gone, right? So there's no clear evidence of need of meniscus root repair during STO. So from this study, they found that even you repair the root or not, the clinical result is the same. So the last topic is about the root reconstruction that's proposed by Dr. Jin-Gu Kim from Korea. Yeah, in the case that I come to see you very late and you cannot cross the gap, so they propose the gastric tendon put into the root. This gastric tendon act like the suture, act like the biologic tissue, act like the soft tissue bridge between the meniscus to the tunnel. Okay, I show you this patient. This patient came to see me with the meniscus root tear, and we performing the meniscus root reconstruction using the gastric tendon, right? Yeah. So the gastric graft have less chance of cut through the tissue because it's the biologic tissue, and you can fix it with the screw. Okay. So the rehab for the root will be very slow. I will not let the patient put the weight on for at least 6 weeks and progressive weight bearing, and then return to the spot. Okay. So this is algorithm of the root repair. So if a patient came to see you very acute, try to repair your meniscus root as soon as possible. If the patient came to see you too late, okay, it's not good to repair the root alone. You need to do some axis correction like STO or UKA or TKA. Your patient came to see you very late. Okay, if you have very big gap, okay, root reconstruction may be the solution or STO. So this is my mother. She is 23 years old. She had root tear on the right side. At that time, she has so much pain on the right side. And this is my mother. This is my wife. Okay, don't confuse. Okay, so you see that 3 years after that, the joint space on the right side become worse. Okay, but the left side is still the same. Finally, she need to do joint replacement. This is my meniscus. You see, she has torn meniscus root and also the radial tear. Okay, so I cannot save her knee. I'm very sorry. So thank you.